morning, good afternoon, and good evening to everyone. Welcome again to this MOH Connect on our platform, the Medical Online Hub by Signalis Group. The favorite for me, as we got different feedbacks from our audience all over the globe. So we do more practical, hands-on live streaming workshop, again from Dr. Erika Mendoza clinics in Venous in Germany. The goal of the MOH is actually to bring together medical experts and discuss state-of-art topics in the field of veno-lymphatic disorders. So today, we have two top-notch experts, Dr. Mendoza and Dr. Omar Al-Farouk. So now, as I have said, that I'm lucky to be again at the clinic, Dr. Mendoza. As you all know, her books and the research, especially on ultrasounds, are reference to many specialists in the field. Same for Dr. Omar, his contribution to the education and dedication of sharing knowledge are significant and second to none. And because at Signalis Group, we always promote the exchange of the scientific knowledge on a global scale, we are also giving you the possibility to actively participate and be a part of these live discussions over the chat or the Q&A function. So please use it, put your questions, your comments here, and Dr. Omar will be the one moderating the event. So on a personal note, I'm actually looking forward to this special event at the MOH and to see a very dynamic, lively discussions with some live cases patient here in the clinic. Having said that, I have the pleasure to introduce our principal moderator and the senior medical advisor of the MOH, Dr. Muhammad Omar Al-Farouk. He is a consultant vascular and endovascular surgeon who's specialized in advanced endovascular and open surgery for critical limb ischemia and diabetic atherosclerosis disease. He also has extensive experience in complex endovascular surgery for aortic aneurysm and lower extremity occlusive disease. Dr. Omar earned his undergraduate degree at Ain Shams University from my beloved home country, Egypt. He also completed his postgraduate vascular surgery training at UK. Also, he obtained a fellowship at Royal College. He's actually examiner at the Royal College of the Surgeon in England. And with that, he has done a lot of research, including surgical education, simulation courses design, milestone on different skills training. He has written numerous research publications and many, many more. So if I could continue saying what he has done, it will be like half an hour of the webinar. But now I would like to hand over to him to take us in the journey in this MOH and also introduce Dr. Erika Mendoza. So to you, Dr. Omar.
Thank you very much, Dr. Mahmoud, for the MOH Connect, which is one of your brilliant ideas that I really enjoy very much. Let me introduce today someone who really doesn't need any introduction all over the world. It's Professor Erika Mendoza. She is specialized in venous investigation. I have enjoyed a lot of her books, her research. She is one of the best really in the field of vascular and ultrasound field. She has done a lot of research about the Chiba. She is one of the great enthusiasts to Chiba. I've also enjoyed collaborating with her during the COVID era. She's really amazing, and I wish to help her in all her research, which all are fantastic ideas, and time by time prove that she was right. She is worked from her office in Munster in Germany since 1997. She has vast experience, and she is also authorized many books about duplex ultrasound, Chiba technique, which has been published in Springer in Germany, both in German and English. She also speaks Spanish, by the way. She provides a lecture which is really amazing in her explanation. I enjoy every second of it. She is also General Secretary of Society of Phlebology since 2015. And she is president of the European Venous Forum. She's also president of German Lymphology Society from 2022. And this is really one of the best 2 years that the society have under her leadership. She also do this meeting in Hanover. She is the president of European Venous Forum meeting 2023 in Berlin. She is president of the Society of Shiva since 2000, and I can go on and go on and go on. The beauty of the MOH Connect today is I always enjoy her skills, her strategy, her philosophy. And this is a clinical webinar that you can learn it immediately and try to do it by tomorrow. And it's practical, and she has done a great effort with Dr. Mahmoud and the webinar and all Sigvara's great team to make this at your hand, at your fingertips. So the mic is to you, Erika, and we will eagerly waiting for all your tips and tricks. Erika.
Wow, thank you. I'm blushing. This is a wonderful introduction. Thank you. Everyone is doing such a lot of great things. I have to thank Sigvaris and especially Mahmoud for catching my idea of doing a hands-on workshop. I always prefer showing things like they are and not talking about it. So we did it at test last year. It was wonderful. And so we aim to do 4 of it this year. I am talking today about the investigation of the sapheno-femoral junction and including a little bit of provocation maneuvers just as an introduction. And then we will investigate 2 patients together. Of course, this presentation is supported by Sigvaris. I can only thank. And I thank also, and again, to Mahmoud, to Mohamed Omar El Farouk, which is also a very, very brilliant person. I love to mix you a lot of times in different meetings. And I think it's great you are supporting this MOH. Just a short reminder, we have a lot of flow provocation maneuvers. Why do we need them? In veins, we have not regular flow when we are standing. And you know that venous investigation of the legs is in standing position. This we have in the classical Valsalva, which was changed to Cremona. And I think this is an interesting thing with the folded straw to blow inside. Then the manual compression of the calf, everybody knows the toe elevation and the dependency maneuver. We will come back to that later. So Valsalva, everybody knows, and everybody knows that it is a little bit difficult for people to understand sometimes how it is to be done. And this deep inspiration and not exhaling and pressing simultaneously, but closing the mouth and press without exhaling. And sometimes it is so difficult to explain to the patients and they are not able to perform it. And if you do it in standing position, they have fainting. So that Claude Franceschi and Roberto Del Frate introduced this folded straw thing and called it Cremona maneuver. You blow into a closed straw, and then you finally have a pressure build up in the abdomen, and you will provoke a reflux if there is an incompetent mouth below. The most classical and surely the most often applied maneuver is the manual compression and decompression of the calf. When you press, you provoke an anterograde flow, and you don't need the patient to understand what you're doing. And it can be done while you're talking to the patient. And surely afterwards, we will do this the most because I will be talking to you about what I'm doing. And so I can do the compression, but it is not physiologic because it is not a movement of a muscle. If patients have pain in the leg, it is painful. And it is difficult because this is a little bit exaggerated. And this was my little daughter and my husband. And if she compresses his calf or he compresses her calf, you can understand and imagine that the flow amount provoked by this disproportion influences the result. This is why it is not so perfect. Coming from the paradigm maneuver, which is pushing the patients, and I thought I can't push the patients in my office, we developed the Woodstock maneuver or the toe elevation maneuver, which is like you see the picture to elevate the toe or to make this and contract the toes. And we will see that in our patients today. And this is a physiologic flow which is repeatable and the patient understands. And especially in fall, we will make the investigation of the perforating veins, especially in the perforating vein investigation. This one is the real life investigation of the walking person. And then sometimes you have a little flow in the vein, which is obvious varicose. So you see a varicose vein, and like here, this is the great saphenous vein with minor compression, decompression. You say, this is not really a reflux, but obviously she has. And the funny thing is that in 2006, simultaneously, Chris Latimer from London and me published the same maneuver. We had the same idea, two stupid persons, the same idea, they say in Germany. And we published this. It looks like we will do this also with the patient. You put this patient with this image and you say, I don't believe it. She has more flow. You put her laying down and wait a little bit, like 20 seconds. And then this is the same, right, saphenous vein. And after emptying the vein with the leg up, it fills and fills and fills. And for me, this is the queen of the provocation maneuvers, because if you have a reflux, in this case, you have a reflux. And if you, after emptying the leg and standing again, have no reflux, the valves are competent. This is like never false negative or positives. This is standing with minor compression. And this is the same vein just after laying down and standing back. So this is the notion we need, because we will apply it later on in the investigation. And this is where we will investigate today the terminal and the pre-terminal valve. It is all about these two valves, the terminal and the pre-terminal. Of course, there is a deep vein valve, and there are tributaries, cranial ones and medial ones in the groin, and the lateral one, which is the accessory anterior saphenous vein. And when we do the investigation, normally standing, we look at the morphology, we longitudinally and cross-section. We do color duplex because we see quick where the blood comes from and where it goes to. But PW to document the findings, because in color, it is not over the time. And to document the findings, the reflex duration, you need a curve in the time. Maneuvers we have seen. So if there are competent valves, the flow is like this. Upstairs, I always say, but the tributaries go down to join the great saphenous vein in the groin. If we have a reflux in the great saphenous vein, we have to know from where, which vein is originating this reflux. Most of the complicated or more obvious refluxes come from the deep vein with an incompetent terminal and pre-terminal valve, and this is called axial reflux because it comes from the heart down the cava, down the iliac vein into the great saphenous vein. This is like this image, a longitudinal cut of the groin. This is the systole, the deep vein, and the superficial vein draining to the heart. And this is the diastole, when the patient lowers the foot again, or you take away the hand in the manual compression, and you have a reflux from the deep vein, from the deep vein into the superficial leg vein. And this means that the terminal valve is incompetent. Again, you measure at the very point of the ostium. This is a deep vein. This is the ostium. This is the superficial, the saphenous vein. And you measure here. This is the systole, anteroretro, and the diastole. You have a long-lasting retrograde flow. But this is for sure the most often found situation in patients with large refluxes. But we have also another situation with 20 to 25% of patients coming for treatment that the terminal valve is competent, and you have a reflux from the tributary of the groin, for example, the epigastric in this case, and the pre-terminal valve is incompetent and the reflux goes down here. This is a so-called para-ostial reflux because this is the ostium. This is the ostium. Blood comes from the deep vein through the ostium, and here the ostium is competent, the terminal valve is competent, and this is the para-ostial reflux with competent terminal valve. And we see again this longitudinal cut of the leg, systole, blood goes to the deep vein, and diastole, the blood does not come out here, it does come out from the epigastric vein. And as this is so important, I repeat it here in images: sapheno-femoral vein, tributary, great saphenous vein, systole, anteroretro, diastole, no flow from the deep vein, no reflux. but from the epigastric. If you differentiate this, it's very important to have a treatment, because I'm completely convinced that these cases are those that profit best from endoluminal techniques. And because you leave a competent terminal valve untouched, and you leave the flow from the epigastric vein draining to the deep vein. This is the cross-section of the same leg. You see the reflux comes from the tributary, not from the deep vein. And if you compare both, this is a larger reflux from the deep vein, and this is a small reflux terminal valve competent, and you have the reflux from the tributary. I think this was my introduction.
Thanks so much, Dr. Mendoza, for the great presentation. I would like to share something first before we go into the discussion more with Dr. Omar and the audience. A recap about what we have done so far to keep you up to date with what we are doing at our platform. Because for us, it's really important that we get to know from you what do you think is actually about our platform, if it's really representing what you need or not. Just to show you a few things, you can see here from the navigation bar that we have different way to go through the website. So either per indication, if you are really would like to dive deep more in some more details, you will see different formats under each indication: DVT, Refluxing syndrome, lipedema, or lymphedema. But also we have created new formats, and these formats helping you to get more information in different ways. Either it's a long webinars, short videos, abstract conclusions from some studies, or detailed studies. What we have something really cool, new, is the MOH Essential, and I would like to keep the first one expert in this platform introduce it to you, Professor Rabi. I think he's well known. I don't need to introduce him, but I will...
Welcome to MOH Essentials. MOH Essentials is a new format on the MOH platform. What is it? MOH itself is a new information platform about the whole field of compression treatment. It is presented by well-experienced and international specialists in the field. The new MOH Essentials is like a video book on the complete field of compression, but with content that is not static as usually books are, but it's growing with each new chapter added in the future. These ongoing new chapters are added according to new medical developments and new results in compression treatment. It contains recordings of basic information about compression treatment, but also summaries of important studies and results in compression, as well as state-of-the-art lectures about compression-related topics. What else do we need to say? We need your input. We would be happy if you would enjoy this new kind of education in compression treatment, and please contact us with your ideas and needs for additional topics you are missing. For further updates, you can find us online.
So that was a bit of introduction about the new format, the MOH Essentials, but you can also have a look at the different videos that have been created on the platform. But as I said, because we have done a lot, and we thought it's really important to show you what we have done. So I would like also to share this video with you to know more about how many experiments that we have so far, different topics.
Thank you so much. Thank you very much. Thank you very much.
Thank you.
Thank you so much.
Thanks so much.
Thank you so much.
And thanks again for everything.
So, as long as we are waiting for the patient to get ready, I think this is a good time that maybe Kyle can share the first whole question, and then Dr. Omar can have a bit of discussion between the patient here already. So, here is the question. Please choose from your point of view. How do you differentiate the vein from a tributary in ultrasound? It's a multiple choice question. So first choice is, they look the same. Second option is, the saphenous vein is covered by axial and the tributary is not. And the last option is, the difference is not important in diagnosis. So we'll keep it for 30 seconds, give you the chance to choose. And Dr. Omar will discuss it more with Erika. So, Dr. Omar, you have also some comments on the presentation.
Yes, this is a very good question. It shows how you diagnose what is the vein under your probe on ultrasound. And this is very important. How much you rely on anatomical, how much do you rely on the site where it is, and is it really important if you have a tributary which is, let us say, 9 millimeter, and your great saphenous is 2 or 3 millimeter, a patient asymptomatic? Does it really make a difference? This is a very clever poll question, I have to say. That's the usual we expect from Erika. And let us see the reply. My dearest Mr. Khaled.
Even though we did not have the topic, but I wanted to see if the information changes throughout
Yes.
the video.
Yeah. Okay, so we'll get a hint. Okay, most people say yes, it's covered by fascia, so they go with anatomy, Erika.
Perfect. Perfect. This is very
Excellent. So
good.
I think it's a correct answer. Well done. So it seems all our attendees are expert in phlebology. So you can see now the duplex screen and Professor Erika in her clinic. And we have very kind patient that would like to thank him very much for helping us.
Okay, thank you so
your
much.
Screen, Erika. Yeah.
Do you hear me? Yes?
Yes, we can hear you very well.
Yes. A bit von Duffin. Yeah. Okay, so this is Miss Balci, a patient with varicose veins, not so many. Do you speak English? A little bit. Okay, good. I sometimes will change to German. Können Sie sich einmal hinstellen? She has wonderful legs, as you may see. Haben Sie Krampfadern? And yes, let's show them. These ones. You see these? And the varicose veins are not so much, like here and there. But you will be surprised. And here is a little tributary. We'll put this light on. Here is a little tributary. Yes. And she came asking for cosmetic help. And as always, before I do this, I make an exploration of the veins inside. So I have put now the jelly on my, and I start in the groin, right leg. You see everything?
Yes, we can see
This
the
is the
common
cross-section.
femoral vein, yeah. Mickey Mouse appearance.
Perfect. Mickey Mouse. The Mickey Mouse im Bein, gucken Sie mal. The Mickey Mouse, the artery, and the artery. She's alive. Yes. There is a. And this is the deep vein. Let's go with the deep vein first. I make the calf compression at yes. You have calf compression, decompression, and we can make another thing. Heben Sie mal die Zehen vorne an. And, genau. Again. Genau. Perfect. This was the Wunsthoff maneuver. And as you are seeing while I'm doing it, we see two things. When we look at the leg from the outside, we would think there is not so much happening inside. But if you see this vein is rather large, we can measure it. It's larger than expected at that point. These are 7 millimeters, which is like the edge to being too large. And we have, I tilt the probe to the top. We see here an epigastric vein joining from lateral or a circumflex perhaps. This is the great saphenous vein. We go down, this is another vein coming from medial, the pudendal vein possibly, joining in. And now I go down and we see what we have asked now perfectly. This is the great saphenous vein covered by the fascia and on the muscle fascia. This is a wonderful saphenous vein. And attention, this is the large vein like Mohammed said just before. Here is the saphenous vein covered by the fascia, and here is the large tributary outside the fascia. This is a wonderful image, and we will start doing here manual compression. This is over. And you see reflux in the tributary here, but I will make it bigger, okay, but not in the great saphenous vein.
Yes, that's very, very nice, because you can see Professor Erika diagnose reflux by color, and this takes experience. You don't need to put Doppler probe, but you can see the color, the upthrust and the reverse of color, and how long the duration. So you can know reflux just by color.
Yes, but if you want to make a documentation of the reflux,
yes,
you always have to do it with, you know, now I'm measuring in the saphenous vein here, and showing there is no reflux. And when I go inside the tributary, you see a long-lasting reflux in the tributary.
That's a grade 3 reflux, more than 2 seconds. Would you consider what is normal is less than half a second reflux? Is that normal?
I think normal is normal is less than 0.5, but this doesn't mean that reflux means more than 0.5. For me, reflux is more than 1 second, because 0.5, more than 0.5 second is very, very short. Now we come to what we are here to learn today. Einmal die Zehe heben. She will, and wieder runterlassen. She put up the toe and lowers it. And if you see this very slowly, I make the same in longitudinal, danke sehr. In longitudinal aspect, let us find the junction. Here you have the junction. This is the femoral vein, yes, and this is the valve place. I like to put it all in one image. This is better. Yes,
that's great.
And now lower the end down, and you see very, very clearly that the reflux is not coming out from the deep vein. Look, in the systole, it flows from the superficial to the deep. And in the diastole, it is not coming out from here. This means the terminal valve is competent, very, very obviously. And so we have to find where this reflux is coming from. And I go up to the epigastric vein. Einmal die Zehe heben und runterlassen. And here, it is not so clear, because as we know, in the epigastric vein, the normal physiologic flow is down. And so this one is just a short, about a second. So I won't be so sure that this is the correct reflux source. Einmal die Zehe heben und runterlassen. It's not as clear. So now we will make another thing. We will look in color, which sometimes helps. And we see, like, it looks like a little bit comes from the deep vein. Stop. Yes, here. Sometimes it comes at the border. So I would say, perhaps it's the deep vein. I would re-investigate. Yeah. You always have to look at the patient if it's Now, the longer she's standing, you observe here, the longer she's standing, nochmal die Zehe heben und runterlassen, the thicker the vein gets, and now you see it would be possibly coming from the deep vein. Sometimes it's not as clear.
Yeah.
Yeah, yes, you saw that. But
Yes,
normally,
yes, very clear.
I will make the comparison. I make half compression and release. And now we wait a little bit to the system refilling. Now elevate the toe on release. And you see the curves are more or less the same. Yes. And
Yes.
my experience is if you have a real large reflux from the deep vein, we will have a patient afterwards. This curve is usually the same height than this one. So you have a big volume coming quickly. If you have like a para-ostial reflux, you can have this situation that the curve is flat and long-lasting. Just to make the... Yeah, do you have a question?
Yeah, we have a question. Someone said, can this be due to pelvic congestion syndrome, or this is unlikely to have a
You
connection
have to-
between?
I mean,
Yeah.
the pelvic congestion syndrome is not an ultrasound diagnostic, but it's a clinic diagnostic. This is a
Oh,
pelvic reflux.
Yeah,
It is, of course, a pelvic reflux because if it comes down the epigastric vein, it is pelvic. But the congestion syndrome means dyspareunia and pain and so on. So not every reflux coming down the pelvic veins is a congestion syndrome. Yes?
excellent. Yes, that's very clear.
So now we have here the saphenous vein, the tributary. We go down the saphenous vein, which is really, really tiny, 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 perfectly healthy. Perfectly healthy, healthy, healthy. There it is, very, very little. We just check. It doesn't talk to us nearly because it's so healthy.
Yeah,
Yes. Perfect. And
so this is ideal case for Chiba, isn't it?
this is an ideal case for Chiba. And you know what I would do with it if I do Chiba? I mean, sorry, every case is an ideal case for Chiba.
Yes. Yes,
You
very
are
sorry.
misguiding
Yes.
me.
I will rephrase it. So this is one of the totally all very good cases for Chiba.
Yes, yes.
Yeah. Okay.
And now you see what I mean. You look, this one is the saphenous vein interfascially.
Yes.
Here is another vein coming. Just stop and have a look. There is a vein joining in.
Yeah.
And this one is also having a reflux, as I suspect now. And this one is an obvious longer than 1 second reflux.
Yes.
No.
So you have two refluxing tributaries going to great saphenous vein, which after the mid-thigh, it looked like a normal vein.
Yes. So we have one reflux coming from the epigastric.
Yes.
And one going a little bit down from the accessory posterior vein, which usually comes from the pudendile labial veins.
Yeah.
But going back to Chiba, so here you see where the vein goes superficial. Yes?
Yes, you can see it very well.
And
We can
if you
see
make
duplex scan
longitudinal,
how you perform on the patient by two views. That's beautiful.
so we have the saphenous vein with a caliber change. This one is thick. This one is very tiny here. Yes?
Yes, yes.
And you have, this one is a tributary. If you make Chiba in this situation, terminal valve nearly competent, you will make the following. Wait. Geben Sie mal die Zehe an und runterlassen. If you see the finger here, Mahmoud, your turn, yes. I close the tributary with my finger. Yes?
Yes, I can see your
Geben Sie
finger
noch mal die
closing
Zehe.
the tributary. Yes.
Runterlassen. There is no longer a reflux.
Excellent. So you know the source of the reflux.
And I saw the drainage pathway. So if I do Chiba, I would just close the tributary and then get the great saphenous vein competent again. Attention, einmal Zehe heben, runterlassen. No reflux. I lower the finger, reflux. So if you close the vein exactly here,
You
this
get the
level, yes,
great saphenous vein back again, the
get
refluxing.
it back to anterograde flow. And in this case, you can do that also with endoluminal laser, because this vein is normally, the tributaries are tortuous. But in this case, it is a very straightforward tributary. Yes?
Yes.
You can put the needle inside the tributary like here. Yes? You can introduce the needle, go up with a laser device until this point and close here, so that you leave the great saphenous vein draining. This is one of the best situations for Jiva. Thank you for introducing the questions. Let's have a look at the other leg.
Oh, we got another question. Do you like laser or foam sclerotherapy? What do you prefer and why?
It depends on the situation. In this case, I would do either surgical, just flush ligation of the tributary on the saphenous vein, or laser, because in both cases you're sure to close just where you want.
Yeah.
If you put the foam, you risk to close all the saphenous vein because you can't stop the foam going up. If the vein was more tiny, yes, it was smaller, then I would imagine to do ultrasound guided foam therapy. But this is a large vein, yes?
Yeah, the problem with foam, you cannot control how much segment it will treat. So here you can pinpoint what do you want to occlude, and laser would be an ideal with a small fiber, laser fiber.
Yes. So you can with the laser fiber, you can be more surgically, more exact, yes?
Yeah,
so
This if you want to lower the cost down,
Yes, this is the left groin. And on this side, the lady has an accessory anterior vein. If you remember, on the other side, we had no. We come back from the beginning. This one is the artery. This one is the common femoral vein. And you have lots of fantastic veins here. You have the pudendal going straight into the junction here. Yes? So this is the sapheno-femoral junction. Here you have a common trunk for the accessory anterior, which is going down here. But listen, I go up, and we have the accessory coming from above. So we have accessory and epigastric joining together into the great saphenous vein, and then we have another epigastric vein coming from medial. So we will make different investigations. There you have the wonderful artery crossing. And again, it looks like it doesn't, a little bit comes from the deep vein, but it could be also coming out. No, there is coming out here. We follow the tributaries. Einmal die Zehe heben und runterlassen. This one doesn't.
There are few questions coming in. Whenever you're free, I can give it to you.
Excuse me?
There are few questions coming in.
Yes.
Okay. One of the question from Bobby Varki. If you close if you close the tip of the tributary by laser, it can reopen after some time, right? This is his question.
It can happen like
after laser.
Like the GSV can reopen. I mean, that happens after laser, but it is very seldom. I mean, it's below 1% in my office.
Yeah. Yeah, I think if you destroy the intima with laser, with a good laser, recurrence also possible, but it's very, very, very slim. And with the recent European guideline for venous disease 2022, laser is the first option for therapeutic treatment. We got another question by Dr. Haydar Aslan, which is a famous doctor from Turkey. Is it possible to use three-way balloon supported sclerotherapy delivery system to control which level you can close under duplex ultrasound? This is a new device where,
this is a very
Yeah.
good question.
yeah,
Because let me just finish something I want to show.
yeah, please.
This is a good question. I use, when I really want to make it with foam, I use the so-called dry foam, where you put only 1 part of liquid and 7 parts of air. Normally you make Tessari, which is 1 to 4, and if
Yeah.
you use 1 to 7, the foam is like very, very viscose.
Yes.
And you can control better the extension. But nevertheless, if you want to preserve the saphenous vein, and this is what we try to do in Shiva,
Yeah.
you shouldn't handle with foam next to the saphenous vein.
Yeah.
Yes, so I
Yes.
just want to use this situation just a moment, just do one maneuver. You have seen, this is the reflux through the sapheno-femoral junction. And when I go below, there is less reflux. And it's like, I don't know exactly where the reflux comes from. So we are going to make a dependency maneuver. Legen Sie sich mal einmal hin und machen mal das linke Bein in die Luft. Yeah, from here you can, okay. So she's having the leg in the air. Yes, very sportive.
For 20 seconds. Yes.
So while she's having the leg in the air, another question.
Yes.
Do you have another question? No. So
yes, we have another question. We have plenty of questions.
okay,
do you prefer laser or radio frequency in your experience, or is there a difference?
Yes, that question is too long to be answered. Just so I come back to that. So now einmal bitte hinstellen. Now lady is coming back to standing, and now look. It takes and takes and takes and flows and flows. You see what I mean? It fills and fills and fills. And if
That's
you
a very good demo. Very good demo.
And if you put the color, you can very well look. Here you see flowing, flowing, flowing. This tributary is guilty. You see that?
Yes, yes, very clear.
Flowing, flowing, flowing. It's flowing, 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 flowing. So sometimes it takes a time to do it, but it clarifies perfectly where the flow comes from and where not. So let us also have a look at this accessory posterior. There is none. No,
so this is a great test to tell you where is the reflux is coming from, and how you manipulate your treatment to tackle it without affecting great saphenous vein.
Yes. So this one is also an incompetent posterior accessory, but I think we have seen most of the reflux also after laying down and standing comes one from the deep vein, obviously. Yes, you see here.
Yes.
You see in the color, you see that best. It comes out here.
Yes, very clear.
And one comes from this accessory, from this epigastric vein here. This is also filling the leg.
Yeah.
And this is
from your experience, when you treat these two tributaries, the big great saphenous vein that we see here will shrink in size, become normal again?
Yes. I have, I mean, in this case, where the terminal valve is semi-competent, I would, and I only treat the tributary. If I could foam just this one, this would be effective only if the terminal valve is really competent.
Okay.
Yes. So in this case, or in both legs, as we have a reflux from the deep vein, I would close in this case, because it's a young lady and I don't want to have, I want to be cutting the leg and so on. I would close this great saphenous vein below the terminal valve, or do what, again, in this case, so if we look at this, we have, again, the saphenous vein, the tributary going out the fascia. Here we have a little perforating vein, which is great. Have a look.
Yeah.
It's so healthy that it doesn't talk to us. But again, I would close the tributary at this point of the inner thigh, where it comes out the saphenous vein.
Yes.
Because I will make an experiment with you if we can see it in ultrasound. If I close it a little bit further down, let's have a look. Here it is. Oh, give me a second. Heben Sie mal die Zehe und runterlassen. I don't know if I'm at the correct place. Here. Okay, mal Zehe heben, runterlassen. You have a reflux there. And if I close the tributary further down, mal Zehe heben, runterlassen. You have no longer reflux here until you open the vein, which is connected tubes. I mean, this is physics. Yes?
Yes.
But this demonstrated if all the reflux goes out the saphenous vein in one tributary, if you close this tributary, you will have a recovery of the proximal saphenous vein.
Yes, that's
so
very good.
I come back to the question with the radiofrequency and laser immediately. Do you have any more question to the patient? Because if not, I would go to the other place. We change the room, which we have a new patient here for the next demonstration. And we leave this lady to go home and we answer questions in the meanwhile. Or do you have questions concerning the investigation of this patient?
No, we don't have a question, and just would like to thank her very much for helping us.
Thank you. Danke sehr.
Hello.
Yeah.
So I come back to the question with the laser or radiofrequency. There are like PhDs done on which is better and which not. I think if you perform them properly, both are good. I personally have both, but for a reason of commodity, I confess, I use the laser because the SLIMS lasers go through the avocat. So you puncture, you go through the avocat, you don't need to have the Seldinger and changing and cutting and doing. And sorry, I use the radiofrequency, especially in those cases. Sorry, in those cases where, for example, a crossectomy was done and the rest of the saphenous vein was there, and I introduce the radiofrequency, and then I give foam before I start lasering, so I can close all the little veins coming from the tributaries and so on, or from perforating way. So this is the option to do the radiofrequency. But in my experience, I did 100 patients with radiofrequency and 100 with laser in my office with this short. I just closed 7 centimeters of the great saphenous vein beyond the terminal walls. And after 3 years, I found no difference in closing.
It was a great clinical skill. So I can see the Doppler in your hand become an investigational tool, and you justify all your argument. And I think the lesson that I always learn from you is that Duplex is not just to discover the reflux, but to discover the source of the reflux, which is extremely important, and to treat the great saphenous vein with its dignity. It's a very valuable organ in the body and shouldn't be easily taken out by many of the vascular surgeons. I think this is what we all have learned from you, Erika.
Okay. More questions?
Yeah, we're open to more questions. Let me start with my...
Yeah. Yes, this is a good idea. But if I start introducing catheters in the leg, which is expensive, and it's working, so why don't do a laser?
Yes, that's a good question.
I do foam as long as I can. I think doing it naturally, I mean, going into the vein and so on, and with a needle under ultrasound control will help. If I think that I will need more devices to do foam, then I prefer doing laser, because in the results of the laser are 97% closure rate in the first session, and of the foam it's less. It's between 18 and 90, depending on the diameter of the vein. And with laser you can treat any vein diameters, without having fears of not closing it. So this is why if I need any additional device, I would directly use the laser.
Okay. We have another question from Arturo Fernandez. If you have ultrasound with VSAA,
The accessory saphenous vein, yes.
yeah, and the reflux goes by the great saphenous vein, and you only close the, I think the USM or the tributary, you treat the VSAA also?
Yes, this is a good question. Also, it is a Chiva thinking. If you have the terminal valve incompetent, the pre-terminal valve competent, and the reflux goes out from the deep vein through the terminal valve and then goes to the accessory vein, usually if you close the accessory vein, and this I do with foam, because if it's not too large. Yes, if it's very large, I prefer laser or surgical. But if it's not so much large, like until 5 to 7 millimeters, I do foam, because the washing out effect of the saphenous vein will always leave free the junction. And this is a wonderful indication for closing only the accessory vein. And I didn't do a study, but I do this since 1997 here in Germany. And I remember 3 patients coming back after years where the accessory vein is, the saphenous vein is refluxive going down, but all the others keep long-lasting competent and have perhaps a recurrence over the accessory, but never in the great saphenous until the thigh. So I think if we go to less harming and why destroying the saphenous vein, which is healthy, it is enough to do the accessory.
Okay. Another question regarding the post-operative period. Which type of compression would you use and for how long?
Yes, this is a very interesting question if you do Chiva. If you do any destroying method, why do you apply compression? To avoid the edema. And then I think it is good to have it for 1 week, 2 weeks after any surgical removal of veins. And in the first time when we did endoluminal laser, we used the bear fiber and so on. It was demonstrated that the pain was reduced by compression. Nowadays, as there is no longer any pain after laser with the radial fibers, and I see the other question, I did never run a study. I use 1490, sorry, and I think there is no so much difference between the wavelengths. But if you use the modern things, the pain is not so much. But if then is the question, do you make tributary surgery or not? Then again, I would offer compression. If you leave the tributaries in situ, or if you even leave the saphenous vein in situ like I do, I always recommend 6 weeks of compression, because you help the vein reducing the caliber and you avoid superficial vein thrombosis. And this is demonstrated in the Chiva group. As we have a kind of, after 6 weeks, the reduction is very slow. In the first 2 weeks, it is very quick. And this is why I then give low molecular heparin, which is another question I've seen, for 1 week. And I look at every patient after 1 week. And if there is a initial superficial vein thrombosis in the saphenous vein, I would give it for a 2nd week. If the vein is already reduced the diameter properly, I stop after 1 week.
Excellent. That's great. And thank you very much for the trick about the dilution of the liquid foam 1 to 7 to give you better control.
Yes.
So the foam will not rapidly flushes with the venous waveform. This is a nice trick.
We will make a MOH in November, I think, or in September, about foam sclerotherapy, where Joseph Grace from Australia, and he has a wonderful device to show everything. And I will make a recurrence with this foam, so we will see how I produce it in one of these MOHs this year. The third question I gave,
Third question, okay.
which was the third one, yes. The third one was if you would recommend compression to the patient we had now, considering she's completely, she has no symptoms. So you can think of this would you recommend compression every day as a prophylaxis or only if you do the treatment of the veins?
That's a very important question. We know that in the recent guideline, European guideline 2022 for chronic venous disease, there was a whole chapter about compression and the recommended compression. So this question tackle the information, the core information. Do you recommend the compression in this patient, the one we have just seen, is going to have Shiva, either every day or as prophylaxis again, obviously TBT, or only for the treatment? And we'll see your reply. It will usually take about 30 seconds to be gathered and to be put into the slide. So please, you can press now on your best choice. It's always a very nice idea of clinical webinars. This is a webinar with the clinical skills. And I'm sure Duplex will expand quite a lot in all our phlebotomy units. And Erika have shown us the clever way of using Duplex, not just to describe the anatomy, but the pathophysiology of the disease will also be elaborated. And that's why the strategy will be much better for the patient. Can we see it? Oh, very good. Every day, which is 50%. It's obviously very nice news for Dr. Mahmoud. Secondly, as prophylaxis, again, a DVT. And third, only for the treatment. So most of you are with the guidelines. If you have a venous disease, guidelines of compression is grade 1A. So that is why I would say, thank you very much. Very nice, correct answer. Some people are moving with different speed to compression, but it is the golden standard when you speak about venous disease. So hopefully we'll wait for Erika to go to another room. She bring to us another patient. And I would like to thank her very much because in Germany, I heard there is a storm. And in spite of this storm, she was very keen to get us her skills through the storm all over the world. The mic is yours, Erika.
I have Miss Blume here with me. And stellen Sie sich einmal hin. We will look at her leg first.
By the way, why do you like to sit on this nice blue colored balloon? Is it better than chair?
Because since I do this, yes, you see the balloon, yes? I used a little chair and I had back pain all the days because I only do this. And since I use the balloon, as I have to move, I think, but I have the balloon for 25 years.
That's a very nice idea. I will buy my balloon tomorrow.
Yes. And perhaps if you show the mobile phone from Mahmoud, you see that I have a large place where the lady is standing on.
Yes, you can see it. Yes.
Because if you use these little ones, patients are like thinking they will fall down. And I have a second image just next to the leg, a second screen. Because
that's a great setup.
Yes, because when you are like doing like this all the time, because you have to look at the ultrasound device, you get neck pain. So the balloon is for the lower back pain and the second screen is for the neck pain. You know, I'm an old lady and I have to look for these things. Thank you. So now this beautiful lady has one varicose vein. Do you see it?
Yes, we can see it. Yes.
Yeah, she comes here because the light is better there. There's my photo. You see this varicose vein? I think you can perfectly see it. And this is the one that we are going to investigate today. Dann kommen Sie nochmal hier drauf. So we start with the sapheno-femoral junction. This is what we wanted to explore today. And as you might have seen, I have a second light above the patient. So I can make clinical investigation and ultrasound just changing the light. And Mahmoud, if you would give me the third favor, come here. And you see, show the patient. And the third, I have a third screen on the opposite side of the wall. Because when I do laser, again, I can look straight forward while I manipulate.
Excellent, excellent, yes.
Yes. I'm a lazy person and make everything so that it is easy.
No, you're making the setup so comfortable, so useful every step of the way. Thank you very much.
Thank you. So now we have another situation. We go slowly. This is the deep vein, left leg.
Yes.
Artery, artery. This one is the sapheno-femoral junction. And we stick to the saphenous vein, which is this one, and go down and see it is not so large.
Normal. Yeah.
But we have another vein here going laterally out. And this is the accessory anterior vein, which is the one we will see here. So anatomy looks like we have a reflux from deep vein through the terminal valve into the accessory anterior. And here we can answer and come back to the question from before. If you foam this, even though the vein is large, you have like a natural barrier here. It is such a thin, and even though foam would go here, and you know always foam goes to the deep vein, the washout effect would avoid to close this segment. So this would also be an option to be foamed, of course, if you see that the diameter is like, let's wait, about a centimeter, 1.2 centimeters, I would prefer doing laser in this large thing. But
I totally agree. Yeah,
if the patient can't afford, or the healthcare insurance doesn't pay the laser or something, or she wants better to be foamed, I say, okay, but we have to be prepared to make 2 or 3 sessions, because perhaps it will not be closed in the first moment. So, but now we are talking about treatment and have not given the diagnostics, because we only have seen the morphology. Now we go with the duplex. And again, we see she's alive. Yes, the artery is moving. I say this like a little bit ironic, and I know this is not the proper way. The PRF is not correct and the angle is not correct, but I always document like this curve, because if the curve is like this, you can be sure there is no severe arterial disease in the leg, and you have not to care about putting compression or not putting compression. I mean, the clinics are not, but I think it's important to have looked at the artery in a certain moment.
So you quickly scan the artery in order to be sure that there is no atherosclerotic involvement in or arteriovenous fistula of that sort. So that's a very nice lesson as well, not just to be tunnel thinking about veins, but to have a look at the artery as well.
Yes. And now I do what I did forget to show you in the other one, but this lady has only one leg to share, so we can have more time with the leg. I always mandatorily do this every day I explore, because imagine you do a thermal ablation or a surgery and you didn't exclude the thrombosis, and you are like treating inside a present thrombosis, which always can happen. And even after the COVID time, so many people getting a small COVID has any kind of thrombosis after, in the 4-6 weeks after, and they didn't notice it. It's very important to make one look at the artery, one look at the deep vein and the compressibility. And also, I think it is important to document that the deep vein is properly drained. Like, geben Sie mal die Zehe und runterlassen. This is a wonderful curve in the femoral vein. Yes. Yeah. She moved her toes, and normally this is not so scientific, but it is practical. If there were any obstruction beyond or higher, you couldn't have this wonderful curve just by moving the toe. So if there is no history, if the veins are compressible and you have this kind of curve, you can relax and say, okay, everything is fine. And now we will try to make this Z. This is a wonderful image.
Yeah.
You see?
You can see the connection exactly between anterior accessory and immediately at the sapheno-femoral junction. It's a beautiful image. Not
It's a
everyone can
beautiful
bring
lady.
this image, Erika.
I have only beautiful patients.
No, you want us to be frustrated with such images.
No. I see so many legs, and then the good ones, I select them for the courses and the workshops. So
Okay.
this one is the deep vein. You see very obviously, and this is what was different in the lady before. There was like a tiny reflux somewhere here, but here is an obvious large reflux from the deep vein through the terminal valve in the little junction to the accessory anterior and then in the accessory vein. This is really a nice image. And if you treat
Thank you, Dr. Mahmoud. He did show us your fantastic setup, which I think is ideal for a phlebology clinic if you want not to hurt your back and your neck. That's fantastic.
Yes. And here you see very well, which is also very seldom. I should never treat you because I didn't need you. It's very seldom to see. This is the great saphenous vein. This is this connection, and this is the accessory anterior vein. Yes. So you see that, and here comes the deep vein. I couldn't put all the three in one level, but this is the very small connection and a nearly aneurysmatic widening of the accessory. And it would be a pity to treat this healthy, this healthy saphenous vein. So now let's go and look for the epigastric ones. Yes, you remember?
Yes.
This is very wonderful, but we need to remember we are here to investigate the tributaries of the groin. Einmal die Zehe heben.
Yeah, it's competent. Yeah.
It's competent.
Yeah, great saphenous, very competent.
Yes.
You are right.
So in this case, it is obvious that this is competent. Yes?
Yes.
And we have perhaps another vein here. No. Then we have to investigate the distal great saphenous vein. And oh, what is there? If we follow the definition, we have a reflux in the great saphenous vein, correct?
Yeah.
Nochmal heben. Runter. Who would treat this?
Yeah, that's a good question.
You know, I sometimes get ironic in Germany. Doctors seldom talk to the patients because it is not reimbursed. And I do. I'm a woman and I like talking. And I always tell the patient, wow, there is a longer.
Yeah.
I tell the patient, if it's a little reflux and I doubt, I say, okay, we treat the other one. And then perhaps we need to treat this, but perhaps not. But here is the reason, die Zehe heben und runterlassen, why the saphenous vein gets refluxive beyond this point. Because if you see here, we have the great saphenous vein from the groin. It is here. It is very, very little refluxive. And if you observe it, observe. Here, whoops, there comes another vein.
Yeah.
In this vein, we can make this tipping finger maneuver. I tip on the refluxing vein, even distant from the place. And you see that this is connected. So you have, I go now down the accessory vein.
Yeah. In the old days, before we have a duplex machine in the surgical field, we used to do this tapping test.
Okay.
Where you tap the anterior accessory in the leg and you feel the reflux with your hand on the thigh, which was not accurate at all. It was called tapping test.
But so now we are following the accessory anterior, and at this point, we think it's dividing, but not. It's just a one of this.
It's a bit tortuous here.
Here it is dividing. You have this one there, and this one here, and this one is the tiny, tiny little one that goes through to the great saphenous vein.
Yeah.
Yes, and this, if you know it, you see it like going here. And again, doing Chiva, I would first close the accessory. Yes.
Yeah.
And wait what happens with this great saphenous.
Yeah. You
Because
know,
if you
yeah, I know you like Shiva very much. If you've seen the new machine of HIFU,
I love
which-
it. I would like
yes,
to do that.
it's ideal for Shiva because now they don't take 8 seconds to close the vein. It is just 0.05 of a second to close the vein. You just say, I want to close this vein and that vein and that vein. Anything
Yes.
below 2 centimeters is good, and you
Yes.
can do it in one session, and
And-
you preserve a great saphenous vein.
And you know what I would do then? I would
Yeah.
close. I would close with HIFU. I'm trying to get a device here to make
Oh,
experiments.
brilliant! You will get a
I would
HIFU machine.
love to. HIFU is the sublimation of Chiva. HIFU is designed for Chiva. Yes.
Gosh,
So I would close this one with HIFU. Yes.
exactly.
This one and attention.
And this one, yeah.
And this
And
little
you can
one.
see the result
Yes.
immediate.
Yes.
Because
Yes.
HIFU is
Yes.
really ideal if you want to do Shiva procedure.
And you don't need a surgeon anymore. You can do it.
No surgeon are
I
redundant
mean,
nowadays.
I like surgeons, never get me wrong.
You're too kind.
So,
But HIFU is a high intensity focused ultrasound, which is a new
Yes.
machine, no puncture, no needle. It will give intense ultrasound beam to close the vein in front of your eyes. The problem is expensive.
yes.
That's the main problem. But
Get this image is a manual compression. Yes, this is
Yeah.
the reflux. Legen Sie sich mal
Yes.
einmal. I mean, in this lady, und machen mal das linke Bein in die Luft. In this lady, we do not need to make sure there is a reflux. Just for
Yes.
didactic reasons, I want to show you how this reflux will change after the dependency maneuver.
yes,
We can make
and you
Share
have very
screen.
nice decoration, Erika, in your clinic as well.
This is from the fifth symposium. I went to New York. This is obviously the Central Park, the tree, and this
Okay.
is the in the fifth symposium, November 22. I made the pictures. So einmal bitte hinstellen. You see the difference?
Yes, very, very clear, very clear. That's a continuous reflux. That's a great, great maneuver, Erika.
Okay. So this is to see the difference between manual compression and this dependency. And sometimes if you have, for example, patients with, is alles okay? Können Sie noch kurz schauen? Patients with this neovasculogenesis after extensive foaming or extensive stripping with not properly closing the junction. Sometimes you can use this just to have time to look all this different sources coming. At the end, you will do foam normally, but if you want to see the sources and be sure you have seen everything, it is sometimes very good to make this long lasting. Sometimes it takes 2 minutes flowing until it ceases, and you can just invest in the patients. Yes.
So what is your strategy in treating this patient?
Yeah, good questions. I would make the accessory vein has a good flow in interfascial way, so you could make a puncture here.
Yes.
Yes, here it is good to be punctured, and you introduce the laser fiber until here, make the local anesthesia and close just here, just this. You wouldn't go around the corner with the tip.
Take it
Yes.
from below the knee with the same caster. Is it because it is too tortuous?
Yes, but yes, okay. So I would start doing just the great saphenous, the accessory anterior, I would really, when I treat the accessory anterior, I foam this because even though tributaries tend to reduce, they are so subcutaneously that I can just close this with laser, and then through the very needle I give a little foam, I give foam, and so you finish it in one session.
Excellent.
If the patient doesn't want to have sclerotherapy, someone doesn't want, you close here and wait, and most of it will disappear, but this so subcutaneous things won't. And then I will have a look if this vein is good or not. And then always my question is, why should I treat a duplex result? She has a larger vein. This vein is edema, and I can understand that she wants to have this treatment. And I think that she won't notice that the GSV is a little bit refluxive. Yes, my aim would be to have it competent. And I think if I close the reflux from the accessory, the GSV will be competent. But even if it would not become competent, and it is like 3 or 4 millimeters, why should I treat it? If the patient has no symptoms, has no visible veins here, I would see her every 1 or 2 years and decide then. Because I still think, why do I have patients with these varicose veins? And the other one it's coming since 3 years to my hands-on courses here, because she has no symptoms. And she says, I only want to treat it if it's necessary. And I say, okay, if I needed a Porsche, I would treat you. But I mean, I'm happy walking by foot to my office. And so I don't need to treat her. This is a little bit unfair to some colleagues, but in Germany we tend to treat everybody because we earn money with it, and in other countries I know it is the same. And so I try to talk with the patient. If the patient is completely say, "Oh, I don't want to see the spiders," and the spiders are fed by a saphenous vein, okay, you can treat it. Yes, but if the patient has no complaints, just because there is a reflux, I would never treat a vein.
Okay. We have a question from Auntie Shiva.
So
Shiva.
Just a moment. Are we ready with investigation of the patient? Are there any questions I should demonstrate at the patient, or can we send
no question regarding demo of the patient? No.
Okay, so then I again change the room. You again make the question with the compression. In this case, yes, she has an edema here. I compress. There is a depression, and she has a swelling, a feeling of swelling. So if you put the question about if we would give compression or not, while I move the room, this would be great. Yes.
Okay, brilliant. Yeah. Here is the second poll question: which reflux type usually provoke more skin changes? That's a very nice question. Axial reflux, perforator reflux, para-ostial reflux. If I have this question in my vascular exam, I really will be difficult. I haven't read that relation between intensity of reflux or anatomy of reflux and skin changes, but I'm sure Erika have known something that we don't know. So if it was me, I would just put a question or any of them, but this is really for discussion with Erika. So let us see what is the opinion of the majority of candidates, and then we'll discuss, and then we'll see the remaining question and remaining chats. Axial, perforator, let us see. Yes, most of them perforator reflux, which you do more skin changes, lipodermatosclerosis. We see it more with perforator rather than axial or para-ostial. So what's your comment, Erika? I don't know the correct answer, to be honest.
Thank you.
Yes, please.
The correct answer, there is a study from Capelli from 2004 already, showing that if you have an axial reflux, the diameter of the vein is much larger than if you have a para-ostial reflux. And so if you have the terminal valve competent, you may assume that the C stage is lower because the volume remaining to the leg is lower. Of course, if you have a distal perforator, this is a difficult question, and we will have time in the MOH about perforating veins, because perforating vein refluxing in the calf, it will make skin discoloration. But if you have a proximal as a dot perforating vein filling with GSV, I don't know. I was surprised to have a look. The thing I know is if you have an axial reflux, the C stage is higher. I have published this in a side effect of any of the studies I have done, because I always differentiate between terminal and pre-terminal valve and CF stage. But this is demonstrated that if you have a terminal valve incompetence, you have a higher C in global. But with the perforators, we need to wait for the next MOH. But I would like to make the last poll again, the poll about the compression. Would you recommend compression? Sometimes, always, or only with treatment? And if it's now difficult to show it, I mean, in this case, the lady has edema in the calf. So I would always recommend compression, at least knee long. Yes. Now I have given the answer. But perhaps we make 30 seconds for the answers, and then we can discuss.
Okay. There is a question in Q&A by Dr. Mangesh Tarti. You know, you always get the anti-Shiva practitioners. So don't worry. We all see this. No problem. So his question is, if laser ablation with biolytic machine, Germany, 1470 millimeter to 1940 with radial fiber, foam for all incompetent and refluxing superficial vein are the best and world-class treatment, why are you mentioning Shiva and HIFO treatment?
Okay. First of all, I don't use BioITech. I use a German.
Okay. Yeah.
Sorry to say this. Second, when I finished my career, I swore primum non nocere. Yes. If you have a breast cancer, 30 years ago, you would always take away the complete breast. And today, even if we are talking about cancer, we are leaving part of the organ inside. I don't understand how an organ that can be used for the bypass, but an organ that is obviously needed to drain the superficial leg veins, why we don't think about preserving it when it is demonstrated that this is possible. So when I started giving Shiva this importance, I was 25 years younger, of course. I thought everybody has to do Shiva. Today I say, do whatever you know, but if you stop and make an ethic consideration of what you do and think that there are possibilities to treat leg veins destroying far less than you do when you do the complete vein stripping or a laser or forming, it is a question of ethics in my eyes to think about not destroying everything. And if you look at the studies for the recurrence rates, Shiva halves the recurrence rate of any ablative method in the comparative meta-analysis. So, of course, no device is behind Shiva, no industry is pushing it, and so on. It takes you a longer time to analyze the leg and to do it properly. So every chance for this method to go forward is very difficult. But if you ask me like that, I have to give the question back, why are you destroying something when there would be the possibility of preserving it?
There are a few questions on the chat. Do you like me to take them, Dr. Mahmoud, or?
Okay, we can come back to the poll. I think the question is, okay, I would offer her every day. I mean, if it's 1 or 2 days out, it's okay. But the illness is already there. We do have to prevent anything, and of course for treatment also. But I think the poll questions is very properly answered. Thank you.
Okay, so we'll take a few questions.
Yes.
What is the maximum diameter of vein that you treat with laser ablation? Do you do up to 12 millimeter, or what is the maximum diameter do you use laser before you use other technique?
This is a very good question, and I tell you, in the beginning, I had to stop at 12 millimeters, and now, when you are used and handle it better with the with the tumor cells around the vein
Yes.
can reduce the vein very, very properly. And then you can make another thing. You can introduce, after positioning the tip of the fiber, you can give into the vein a little bit of 3% polydocanol.
Yeah.
Not small, liquid. You will have a second shrinkage.
Yeah.
And of course, when I say I have like 98 to 99% of patency of closure in this first intention, it is always those with 15 millimeters or those taking anticoagulation, which I don't discontinue, that don't close completely in the first session. But you can always redo it. You can always, if there is a little bit of patency, give foam inside. And this is what I explain to the patients. They say, if you are anticoagulation and you have a large vein, you of course could discontinue it, you could make a crossectomy and so on. But it is much easier for the patient to have a laser ablation and say, in a week, I will look, and if I have to redo something, we will do it. Yes, but it is still all the time the anticoagulation going and so on.
That's a great clinical question. The other question, how to treat small veins over the foot causing discoloration? So if you have dorsum of the foot with the small veins, what do you do?
Normally, the small veins of the foot are either because you have a deep vein thrombosis or you have a large reflux in some vein of the leg. So I always treat first the reflux source and tell the patients in 3 months we have a look, what is the fate of the veins in the foot? And often, I mean, those veins, the larger the vein, the better it recovers. If you have only a small vein at the foot, you will have to foam it after the time. And I know lots of you don't use foam in spiders, and I know lots of you think that at the foot you can't foam or you can't make sterile therapy. I always test somewhere in the leg, and if they have not so many scarification or they have not so many pigmentation, I try and do it in the foot very, very, with 0.5% and very slowly and so on. And I think you can help them with sclerotherapy, but always first treat upstairs.
Last question, I think from Russia, by Yulia and Zukia. How often you investigate patient to decide to operate on great saphenous vein or not?
That depends. I mean, if somebody comes and says, I'm suffering, my leg is itching, it is red, and it is obvious that the problem comes from the saphenous vein, I would talk to the patient, explain him the procedures, and at the day of the procedure, investigate the leg again. But like the first lady, she's absolutely without symptoms. I would explore her every 2 years and wait until I have some ladies coming or people coming every 2 years since 20 years. And sometimes when suddenly there is edema, then I say, okay, now we should.
Excellent. So I enjoyed every femtosecond of your cases, your argument, your strategy, your philosophy. You really have taught us a lot. And I would like to give the mic to the brilliant idea of MOH, Dr. Mahmoud Al-Ban. Mic to you, Dr. Mahmoud.
And I thank you, Mohammed, because you are a wonderful interviewer. You
That's very kind.
Around you with very, very good questions, and I thank the audience for the good questions. Some others.
I will buy the big blue ball tomorrow.
Okay.
So maybe before I start closing, I would like to ask Dr. Erika for a take-home message after the whole day. So if you would like to phrase the event and the discussion and the cases, what would you give us?
Again, I mean, I'm strong in ultrasound. I was made big in ultrasound, and I think the best thing you can do is to learn analyzing what the patient has, because any strategy you will do it better when you know what you are treating. And if you have recurrences, you can analyze them better if you know exactly how the situation before the treatment was. And so duplex is really, you shouldn't treat a patient if you don't do a proper duplex, knowing where the reflux comes from and where it drains. And all the other questions were practical things, and we can think next year of doing a Chiva and luminal treatment, so you can see how I decided and so on. We can think of it, and perhaps I can do a LIFO as hands-on. I would be wonderful. And yes, the take-home message is know what you're doing, because you see before you start. And as a philosophy at the end, I had a colleague come into a Chiva course, a very skeptical colleague, and he said, I don't know if Chiva is the best method, but I know that after learning to investigate to apply Chiva, I am a better phlebotomist. And this was, so just learn, because with the ultrasound well applied, you have much more instrument to decide.
Yeah, I think that's really a great closing of the event. I would like to thank you again, Dr. Erika Mendoza, to Mohammed Omar Farouk, for this really great discussion. You can see how the interaction was really positive from the audience. Also, thank you so much for the audience for giving the time to have the possibility to also put your comments and the questions. I would like also to encourage you all to go again to the MOH platform, the link on the chat. You will see this recording of this session available very soon. We'll also split it in small sessions per patient, so you will have the possibility to jump between the patient to look what actually if you are missed something. So at the end, thank you for very much, everyone. Thanks again, Dr. Erika, Dr. Omar, and yeah, see you soon. As mentioned earlier, this is not the last. We'll have another 3 sessions this year on a different topic, venous ulcer, with live case patients from here from the clinic. So see you soon and have a nice evening. Thanks so much.
Bye.
Goodbye.